Welcome to the funnel effect.
Today, we're taking a deep dive into a condition that sounds incredibly technical, but the stakes are genuinely life and death.
Right.
We're talking about long QT syndrome, or LQTS.
That's right. And our source material for this is a really comprehensive review article from the New England Journal of Medicine. It's a key piece of clinical guidance titled simply Long QT Syndrome, and it's authored by Peter J. Schwartz, MD, and Leah Crotty, MD, PhD.
Our mission today is, I think, very focused. We want to unpack the complexities of LQTS. It's a genetic disorder, and tragically, it remains a leading cause of sudden death in young, otherwise healthy people.
But, and this is the crucial part we want you to hear, there's this astonishing reality that extremely effective therapies now exist.
Exactly. If you walk away with one insight today, it should be this. LQTS is a manageable condition, but, and it's a big but, only if it's correctly diagnosed. We're really learning how to turn what is a potentially catastrophic invisible risk into, well, a chronic condition with a near-normal quality of life.
I think we have to start with the historical context. It sets the tone so perfectly for how difficult this diagnosis used to be, and why a review like this is so important.
It really does.
You mentioned something that's just astonishing. In 1957, a respected textbook on electrocardiography literally dismissed measuring the QT interval. It said it had little usefulness.
I know. It's almost unbelievable given what we know now. It really speaks volumes about the early resistance to the idea that, electrical timing, rather than just structural damage to the heart, could be lethal.
So physicians were just looking at the anatomy.
Pretty much. Think about 1957. The technology for precise measurement was, well, it was rudimentary. And the molecular mechanism was a complete black box. Doctors were focused on the physical heart, not these invisible things called ion channels. Why would you worry about measuring something that was hard to measure and whose clinical meaning was, completely dismissed by the experts?
But the irony is that in the very same year that textbook came out, the first clues were already appearing.
Exactly. In 1957, two doctors, Jervell and Longielsen, published their report. They linked this QT interval prolongation with sudden death in a specific family.
And that was the family that also had congenital deafness, right?
That's the one. And then soon after, other reports started trickling in. Romano and later Ward, they documented the same critical issue, but in patients who had perfectly normal hearing. It took a while, but by the mid-1970s, the medical community finally started grouping these related but slightly different presentations under one unified umbrella: long QT syndrome.
So in just a couple of decades, we went from completely dismissing the measurement to realizing this electrical prolongation was an invisible killer.
A huge shift.
So for you listening, let's just solidify that definition. LQTS is a genetic condition. It's characterized by a prolonged QT interval on a resting ECG, and that translates into a high risk for life-threatening arrhythmias.
And those arrhythmias are often triggered by sympathetic activation, so physical or emotional stress.
And that leads directly to the core clinical tragedy of this whole thing. Sudden cardiac death is often the very first symptom.
And if you only diagnose it post-mortem, you failed entirely. The authors of this review, Dr. Schwartz and Dr. Crotty, they make a very strong, I would say almost a moral argument here.
What do they say?
They state that given how effective treatment is now, the very existence of patients with undiagnosed and therefore untreated LQTS is, and I'm quoting, inexcusable.
Inexcusable. That's such a powerful word. It puts a tremendous ethical and clinical burden on physicians, doesn't it? To just maintain a high index of suspicion.
It absolutely does.
So if the failure is so inexcusable, why does it still happen? Is it a lack of awareness in primary care, maybe the cost of genetic screening, or are doctors just not taking the subtle symptoms seriously?
It's likely a combination of all those things, but I think awareness is the biggest factor. Unless a physician is proactively measuring the QT interval and knows what the abnormal values and specific T-wave shapes look like, or, asks about a family history of sudden death, they will miss it.
And the symptoms themselves can be misleading.
Very misleading. They'd be vague, like vertigo or short-duration fainting, which is called syncope, and those are so easily attributed to more benign causes, like dehydration or even a panic attack.
So the subtlety of the condition in many people who carry the gene, it masks a catastrophic risk.
And that subtlety is what allows the diagnosis to be missed far too often.
That really clarifies the urgency. Okay, let's try to quantify the problem. What does the actual prevalence snapshot look like?
Well, based on a major prospective study, they looked at 44,000 infants. The documented prevalence is about 1 in 2,000 live births.
1 in 2,000, that's That's not vanishingly rare.
Not at all. And the true prevalence is almost certainly higher than that number.
Okay, why the discrepancy?
Because those initial large-scale studies only included patients who were phenotype positive. They had to actually show the characteristic prolonged QT interval on their ECG to be counted in the study.
So they didn't include the people who are genotype positive but phenotype negative.
Exactly. The silent carriers, the people who carry the pathogenic genetic variant but haven't yet manifested that electrical sign on a resting ECG, are still part of the LQTS population. They're still at risk. And critically, they can still pass the gene on to their children.
So if you count for those silent carriers, the real number gets pushed up significantly.
It has to. The complexity of diagnosis is built right into the definition of the disorder.
Which brings us neatly to the molecular level. Let's unpack the genetic blueprint of LQTS and focus on these ion channels that define the heart's electrical rhythm.
Absolutely. The mid-1990s were just a pivotal time for this. Between 1995 and 1996, researchers identified the three major genes that are responsible for, well, roughly 90% of all LQTS cases.
And those are KCNQ1, KCNH2, and SCN5A.
That's them. These genes basically provide the instructions for making the ion channels that regulate the flow, the influx and efflux of potassium and sodium. And that flow is the fundamental driver of cardiac repolarization.
Repolarization being that electrical reset phase after every single heartbeat. Okay, so let's start with the largest group, LQT1.
LQT1 accounts for about half of all cases, approximately 50%. It's driven by pathogenic variants in that first gene you mentioned, KCNQ1.
And what does that gene do?
It creates a potassium channel that's responsible for conducting what's known as the slow-delayed rectifier potassium current. We just call it ICase.
So how does a failure in that channel translate into actual danger for a person?
Well, the ICase current is absolutely crucial for repolarization. So if you have a variant in KCNQ1, you suffer a reduction in that ICase current. It's essentially a loss of function.
Which makes the QT interval longer.
Exactly. But what makes this so relevant to a patient's life is when that current is most important. The ICase current becomes the dominant current during periods of adrenergic activation.
So exercise, a fight or flight response, even high emotion.
All of it. When your heart rate increases, ICase needs to ramp up really quickly to shorten the QT interval appropriately. If it can't, because the channel is defective, the repolarization just fails to keep pace with that faster heart rate. That causes instability, and that can trigger a life-threatening arrhythmia.
That is a perfect explanation for why physical exertion is such a classic trigger for LQT1. We'll definitely come back to that. Okay, next up, LQT2.
LQT2 represents about 40% of cases. This one is caused by variants in the KCNH2 gene, which used to be known as HRG.
And that also encodes a potassium channel.
It does. This one is responsible for the rapid delayed rectifier potassium current, or IKR. It's also a key repolarizing current. And just like with LQT1, the mechanism is usually a reduction or a loss of function, which prolongs the QT interval.
Is there anything unique about this IKR channel?
Yes, and it's a huge clinical point. IKR is particularly susceptible to being blocked by external factors. And this is why LQT2 patients are so exquisitely sensitive to a massive range of common medications.
And that leaves LQT3, the remaining 10% of the major types. And this one, it works entirely differently, doesn't it?
It does. LQT3 is the outlier. It's caused by variants in SCN5A, which encodes the voltage-gated sodium channel. This channel conducts the inward sodium current, IN.
So instead of a potassium problem, it's a sodium problem.
Right. And instead of a loss of function, LQT3 variants cause a gain of function.
A gain of function. What does that mean here?
It means the sodium channel fails to inactivate properly. It gets stuck open and it leaks, resulting in a persistent inward sodium current. This tiny, lingering inward positive current during the plateau phase of the action potential is what prolongs repolarization and leads to the long QT.
That's a really crucial distinction. So we have two major types caused by not enough outward potassium current and one caused by too much inward sodium current.
And yet all three result in the same potential for fatal electrical instability.
Okay, beyond those main three, the source outlines several less common forms, but they're often quite severe.
Yes, first we should go back to the syndrome that really started it all. Jervell and Lang-Nielsen syndrome. This is a severe recessive form of LQTS.
Recessive meaning you need a faulty copy of the gene from both parents?
Exactly. It requires homozygous or compound heterozygous pathogenic variants in KCNQ1 and also KCNE1. And the key clinical feature here, the thing that often leads to diagnosis, is its association with profound congenital deafness. These patients are often diagnosed very early because of that combined severe phenotype.
And then there's Timothy syndrome, which sounds like it affects more than just the heart.
It's a multi-system condition. It's caused by variants in a calcium channel gene, CACNL1C, and while it certainly causes LQTS, it's very complex. It often includes associated skeletal abnormalities, distinctive facial features, and significant neurodevelopmental delays.
And finally, a category called the calmodulinopathies.
The calmodulinopathies are genetically quite intriguing. They're caused by variants in 3 completely distinct genes: CALM1, CALM2, and CALM3.
3 different genes.
Here's the twist. These 3 genes are located on different chromosomes, but they all encode the exact same protein, a protein called calmodulin.
And what does calmodulin do?
Calmodulin is a critical regulator. It modulates the function of various calcium channels in the heart. When you have pathogenic variants, they impair calcium channel inactivation, causing calcium influx to linger too long, which once again prolongs the QT interval. These mutations often present with very early onset, life-threatening arrhythmias.
Okay, that gives us the full spectrum of the primary genetic causes. But what I found particularly fascinating in the review was the introduction of modifier genes.
Ah, yes.
It seems like the simple presence of one of these pathogenic variants doesn't actually tell the whole story of how severe the disease will be.
It doesn't, not at all. Modifier genes are common genetic factors. Often they're just single nucleotide polymorphisms or SNPs. They act like, well, like volume controls. They can significantly dial up or dial down the clinical severity and presentation of that primary disease-causing variant.
So they explain why 2 people with the exact same primary mutation might have vastly different outcomes.
Precisely. One might have a QTC that's just borderline, while the other's is severely prolonged and they're having symptoms.
Let's talk about that example from the South African founder population. It's such a dramatic illustration of how powerful these modifiers can be.
It's a perfect textbook example. You had hundreds of individuals who were all carriers of the exact same primary mutation. It was KCNQ1A341V.
The same mutation in everyone.
Yes. Yet when they measured their corrected QT intervals, their QTC, it spanned this huge spectrum from borderline normal all the way up to severely prolonged. The difference, the source notes, is overwhelmingly due to the influence of these modifier genes interacting with that core variant.
So why does understanding this level of complexity matter in the clinic? What are the implications of being able to spot these modifiers?
The implications are enormous. 2, really. First, immediate risk stratification. If we can identify modifiers that we know increase a patient's QTC, we might opt for more aggressive therapy, maybe adding a drug like mexiletine or considering a procedure called left cardiac sympathetic denervation earlier, even if their QTC isn't profoundly long yet.
And I suppose the opposite is true.
Right. If we see protective modifiers are present, we might be able to avoid unnecessary interventions and the side effects that come with them.
And the second implication?
It opens up whole new drug design pathways. If a modifier gene, like one called NOS1AP, is shown to influence the severity of the arrhythmia, then the biological pathway it regulates becomes a potential drug target. You could design a drug to shorten the QTC in a way that completely bypasses the original channel defect.
That really moves us squarely into the realm of personalized medicine. But the reality of genetic testing today is often...
Well, it's confusing, especially when these reports come back with gray areas, these variants of uncertain significance or VUS. VUS are a constant headache for physicians. It simply means a variant has been identified, but the available scientific evidence, things like population frequency, functional data, family history, it's all insufficient to definitively categorize it as either benign or pathogenic.
So the physician is left treating a completely unknown risk.
They are. It's a core ethical and clinical dilemma. Do you treat the patient as high risk, which might be unnecessary, or do you not treat them, which could be fatal?
So what happens with a VUS? Does it just stay uncertain forever?
No, thankfully.
Yeah.
The source notes that VUS are periodically reclassified. This reclassification process is based on increasing knowledge. How robust is the patient's clinical phenotype? Does the variant consistently show up with the disease in their extended family? Has a functional evaluation in a lab actually confirmed that the variant impairs the ion channel?
So it's a moving target.
It is. This ongoing reclassification means that the management strategy for a patient with a VUS has to be reviewed continually. It might even change years after the initial diagnosis.
And what about the opposite scenario? The patients who are clearly phenotypically LQTS, they have all the electrical and symptomatic signs, but their genetic test comes back negative.
That happens in about 10 to 15% of clinical cases. For these genotype negative patients, The hypothesis is that their susceptibility isn't driven by a single high-impact variant.
So what is driving it?
It's likely the aggregate contribution of many common genetic variants, what we call a polygenic risk score. Essentially, they've been dealt a bad hand of many low-impact variants that, when they're all combined, push them past the threshold for repolarization stability. And that leads to the clinical syndrome.
And they still require treatment.
Absolutely. They require treatment just the same, even without a single clear monogenic cause being identified.
Okay, that provides all the necessary molecular context. Let's move to how this is actually diagnosed in the clinic. What are the key features to spot on the ECG?
Right, so we move to the gold standard, the measurement of the QT interval corrected for heart rate, which we call the QTC.
The source mentions that Bazet's formula is still the one that's used, even though it has known limitations. Why do we stick with it?
You're right, it does have limitations. It tends to overcorrect at high heart rates and undercorrect at low ones. But it remains the clinical standard for a simple reason. It is highly effective at reliably discriminating between normal and abnormal values across diverse populations. And that includes infants. It's the established benchmark we all work from.
So what are those benchmark values?
The upper limits of normal are generally defined as 440 milliseconds for men and 460 milliseconds for women.
And when does the real red flag go up for arrhythmic risk?
A QTC greater than 500 milliseconds. That is a crucial threshold. It's a marker that helps us discriminate patients who are at moderate risk from those who are at high arrhythmic risk. A number like that demands immediate and aggressive therapeutic consideration.
The measurement technique sounds absolutely vital here. A few milliseconds could be the difference between a normal finding and a high-risk diagnosis.
Precision is everything. The QT interval has to be measured from the very start of the Q wave all the way to the precise point where the T wave returns completely to the isoelectric baseline.
And the source says to use the longest one you can find.
Yes. The longest QT interval found across all 12 leads of the ECG is the most important value to document. And critically, the so-called tangent method, where you draw a line tangential to the steepest slope of the T wave, is often discouraged.
Why is that?
It saves time, but it frequently underestimates the true duration of repolarization, and that could lead to a misdiagnosis.
But it's not just about the length, it's about the shape, too. You mentioned bizarre morphologic changes. What are the specific T-wave patterns that should immediately make a clinician suspicious of LQTS?
Pattern recognition is an essential skill here, almost as important as the measurement itself. These bizarre morphologic changes concerning ventricular repolarization often point towards the underlying genotype.
Can you give us the visual signature for the major types?
Sure. In LQT1, we often see a very broad-based T wave. Sometimes it's described as having a camel hump appearance. In general, you might see biphasic T waves or deep negative T waves. But the key pattern, and this is particularly frequent in LQT2 patients, is the notched T wave.
A notched T-wave, what does that look like?
It's where the T wave appears to have two separate peaks or a distinct notch right in the middle.
And why are those notched T-waves in LQT2 so significant?
They're a specific marker of increased arrhythmic risk. They are thought to be caused by early after depolarizations, which is the very mechanism of instability in LQTS. That notch essentially reflects the heart trying to restart repolarization, failing, and then successfully completing it a moment later.
And then there's T-wave alternans. That sounds particularly alarming.
It is. T-wave alternance is a severe sign of major cardiac electrical instability. It means the shape or the height of the T-wave is alternating from beat to beat, even when the heart rhythm is otherwise regular.
And what does that signify?
It's considered a prefibrillatory sign. It's a warning that Torsades de Pointes is imminent. Interestingly, this exact phenomenon has been reproduced in the lab by electrically stimulating the left stellate ganglion in cats, which just confirms the strong sympathetic nervous system component to this severe electrical breakdown.
So if the ECG looks suspicious, what are the actual symptoms the patient might report that confirm Torsades de Pointes is happening?
Well, the underlying malignant event is Torsades de Pointes, or TDP. It's a rapid twisting form of ventricular tachycardia. If TDP is sustained, it usually degenerates into ventricular fibrillation, which causes cardiac arrest and, of course, sudden death.
And the warning signs before that happens?
If a patient with a known or suspected prolonged QT reports short-duration syncope fainting, or even just transient vertigo or lightheadedness, the physician has to be immediately alerted to the possibility of TDP. These brief episodes are the body's warning system before a sustained life-threatening collapse.
Let's talk about those ambiguous cases where the QTC is just borderline and the symptoms are vague. What diagnostic tools beyond that resting ECG help experts confirm the diagnosis?
In those borderline cases, we rely heavily on two main tools: the Established Diagnostic Score, which is sometimes called the Schwartz score, and the Exercise Stress Test. The score gives us a standardized preliminary assessment.
Tell us a bit more about how that Schwartz score works.
It's a robust point system that weighs several different factors. For example, it gives 3 points for a profoundly prolonged QTC 480 milliseconds or greater, and that scales down to 1 point for a QTC of 450 to 459.
So it's not just the ECG measurement.
No, it also incorporates clinical history, episodes of syncope, for instance.
Yeah.
And syncope that happens during stress earns more points than syncope at rest. Those T-wave abnormalities we talked about, like the notch T-waves or T-wave alternans, they add points. And crucially, family history is weighted very heavily.
So if you have a first-degree relative with confirmed LQTS.
Or unexplained sudden death under the age of 30, that adds substantial points to your score.
And how do we interpret the final number?
A score of 0 to 1 point suggests a low probability. 1.5 to 3 is intermediate, and that's where further testing is vital. And a score of 3.5 points or more indicates a high probability for LQTS.
But it's just a preliminary tool.
We have to stress that. Its primary use is for that initial assessment. Its utility is limited once a patient begins therapy, and it should never, ever be used as the sole basis for invasive decisions, like implanting a defibrillator.
The source material seems to really elevate the exercise stress test above other provocation tests. Why is it so useful in these ambiguous cases?
It's considered the most useful and specific test available for challenging diagnoses. You have to remember, LQPS is a disorder of electrical reserve. A healthy heart has to shorten its QT interval as the heart rate increases during exercise. In many LQTS patients, especially LQT1, the shortening is sluggish or it's just absent.
So what is the specific sign on that test that confirms LQTS?
The hallmark finding, which is highly specific for LQTS, is a marked QTC prolongation at the 4th minute of recovery.
So after the exercise stops.
Exactly. As the heart rate slows down post-exercise, the faulty ion channels struggle to reset, and that causes the QTC to snap back to an extreme length. Other important clues can be seen at peak exercise, like a complete fusion of the T wave and the preceding P wave, which is a sign of severe electrical overlap.
Are there any tests that have fallen out of favor or are now actively discouraged?
Yes, a couple common ones. The stand-up test, which was designed to provoke a brief tachycardia, has shown very limited diagnostic value. But more importantly, the epinephrine challenge.
I've heard of that one.
It was historically proposed for diagnosis, but it is now strongly discouraged. The source confirms that this test has dangerous arrhythmogenic potential. It can severely alter ventricular repolarization, even in healthy people, creating false positives or, much worse, actually inducing torsades de pointe in a susceptible patient.
So the guidelines are clear on that.
Absolutely. As per major guidelines, epinephrine testing should simply not be used for diagnosis, period.
That sets a very clear line for clinical practice. Let's now connect the genotype back to the clinical reality by talking about these gene-specific triggers. This is where patient education becomes literally life-saving.
This is perhaps the most practical and fascinating part of managing LQTS. The specific ion channel defect dictates precisely when a patient is most vulnerable.
So let's start with the LQT1 patients. Their channel failure is most pronounced when the body is under stress.
Exactly right. LQT1 is the adrenergic or sympathetic type. High risk occurs during intense physical or emotional stress or sudden arousal. And the source specifically notes that life-threatening events are particularly common during swimming.
Swimming specifically, why?
The combination of cold water, the physical exertion, and that adrenergic surge is just a highly destabilizing cocktail for them. Management includes strict limitation of strenuous competitive exercise and avoidance of, say, sudden confrontations.
Okay, now moving to LQT2, the potassium channel linked to those notched T waves.
LQT2 patients are defined by their acoustic and rest-related triggers. Their high-risk window is exposure to sudden, sharp noises.
Like what?
Like an alarm clock, a dropped tray, a telephone ringing, especially when they are suddenly woken up from sleep. That sudden shock of acoustic arousal, without the heart rate stabilizing first, can trigger TDP.
So the management advice is very practical.
Extremely. Avoid alarm clocks and phones in the bedroom. Manage environmental noise as much as possible. Very simple things.
And there's a specific, highly concerning risk for women with LQT2 in the postpartum period.
This is a critical insight that is often missed. Female LQT2 patients are at an increased risk during the postpartum period, and the likely mechanism is severe sleep disruption.
From caring for a newborn.
Exactly. Chronic lack of sleep, combined with sudden interruptions to that sleep, leads to greater rebound periods of arrhythmogenic REM sleep. The management recommendation includes ensuring sleep protection, often by having a partner or family member share the bedroom to help with the infant and make sure the mother gets some uninterrupted rest.
And finally, LQT3, the sodium channel gain-of-function type. Their danger zone is completely different.
Completely. Since LQT3 involves that persistent sodium leak, the risk is highest when the heart rate is slow. The heart just has more time for that leaky sodium current to build up and destabilize repolarization. Therefore, arrhythmias occur primarily at rest or when the patient is asleep.
So the management there is about ensuring a rapid response if something happens.
Yes, potentially by having a home AED and ensuring the patient doesn't sleep alone. It's truly staggering how the location of a microscopic channel defect dictates whether your biggest risk is running a marathon or answering the telephone.
That staggering difference leads us naturally to the most vulnerable population, infants, and the connection to what we call SIs.
This is one of the most compelling public health aspects of LQTS. Infants who experience a cardiac event in the first year of life face a very, very high mortality risk. And traditional beta blocker therapies are often not enough protection for this severe early onset risk.
How significant is the contribution of LQTS to infant mortality?
It's substantial. Up to 10% of infants who die suddenly in the first year of life, or even experience sudden in utero death, are found to carry LQTS-causing genetic variants. If a newborn has a prolonged QPC on their screening ECG, their risk for sudden death is immediately increased.
And without that genetic testing, these deaths are often just categorized simplistically.
Exactly. A sudden death in an infant in the first few months of life is often just labeled sudden infant death syndrome, or SIDs, and that can lead to unresolved grief and sometimes even suspicion of foul play.
So this molecular link really strengthens the case for widespread screening.
It absolutely does. It strengthens the rationale for widespread ECG screening in the first month of life. Identifying these high-risk infants who need aggressive, immediate intervention is a truly preventable measure.
And from a legal or a social perspective, this genetic knowledge must change the way we investigate multiple sudden sibling deaths.
Absolutely. The critical understanding of familial LQTS calls for restraint before anyone jumps to the conclusion of infanticide in these horrible situations. A thorough genetic and cardiac screening have to be performed first because this inherited disorder is very often the root cause. It shifts the entire narrative from a criminal tragedy to a preventable disease.
That sets the perfect stage for the good news, the therapies. Let's break down the 4 cornerstones of effective LQTS therapy, starting with the basics, like lifestyle and supplements.
The foundation of management is non-pharmacologic. First and foremost, avoidance of all QT prolonging drugs is mandatory. There are resources like the Credible Meds list online that are essential tools for patients to cross-reference any new prescription they receive.
And what about supplements?
Since LQT2, patients are so sensitive to low potassium, maintaining adequate plasma potassium levels, usually through potassium supplements, is often advised to help stabilize their repolarization reserve.
Okay, now moving to the mainstay of therapy, beta blockers. They've been used since the mid-1970s.
Beta blockers are the first-line defense. Their efficacy has been repeatedly confirmed across all the major genotypes. They are the cornerstone because they blunt the effect of the sympathetic nervous system, reducing the heart rate and mitigating those triggers we talked about for LQT1 and LQT2.
But the source made a really crucial distinction. Not all beta blockers are equally effective here.
This cannot be overstated. Clinical practice has to adhere strictly to the evidence. The review confirms that only 2 beta blockers have confirmed efficacy in preventing arrhythmic events. Propranolol, which is typically dosed quite high at 2.0 to 3.5 milligrams per kilogram per day, and nadolol, dosed at 1.0 to 1.5.
And the authors explicitly warn against one in particular.
Yes. They state that metoprolol should not be used because its efficacy is significantly lower in this specific patient population. That's a critical practice-changing piece of information.
If a patient on beta blockers still experiences a life-threatening event, what are the usual culprits for that failure?
The vast majority of treatment failures aren't due to the drug itself failing. They're due to human error. The 2 main causes are non-adherence to the prescribed drug regimen, often because patients feel totally fine and asymptomatic, or the unfortunate use of a concomitant QT prolonging drug that was unknowingly prescribed by another doctor, which effectively counteracts the protective effect.
Should beta blockers be prescribed even for those people who are genotype positive but have no symptoms, the phenotype negative carriers?
Generally, yes. The potential benefit of preventing a sudden death far outweighs the minimal side effects for most people. Beta blockers are routinely prescribed for these carriers. There are some rare gene-specific exceptions, like an asymptomatic LQT1 man over the age of 25, where the risk is considered low enough to potentially defer medication, but generally prophylaxis is the standard of care.
Okay, now we move to a more aggressive but highly effective option, left cardiac sympathetic denervation, or LCSD. This is a procedure, not a pill.
LCSD is a significant intervention, for sure, but the data supporting its efficacy is just overwhelming. It's typically performed via thoracoscopy, a minimally invasive surgery, and it involves the surgical removal of the lower half of the stellate ganglion and the first four thoracic ganglia, T1 through T4.
And removing the lower half is a key detail.
It's a refinement, yes, aimed at preventing a complication called Horner's syndrome.
So what exactly does cutting that sympathetic nerve supply to the heart achieve?
The rationale is brilliant, and it's rooted in the pathophysiology we've been discussing. LCSD achieves a striking anti-fibrillatory effect. It dramatically reduces the release of norepinephrine, the stress hormone, at the ventricular level. And crucially, it does this without causing post-denervation supersensitivity and without significantly reducing the patient's resting heart rate, which can be a problem with very high-dose beta blockers.
The efficacy stats you mentioned are just astounding, a 90% reduction in subsequent events.
It is a major therapeutic victory. Studies show that when LCSD is performed in patients who are experiencing electrical storms, and that means recurrent life-threatening ventricular fibrillation causing multiple appropriate shocks from their ICD, the procedure reduces the annual incidence of those shocks by a staggering 90%.
For a patient living in constant fear of their device firing, that must be completely life-changing.
It restores their confidence and their quality of life.
So given that data, when should LCSD be implemented in the treatment plan?
The consensus among experts is firm. If a patient experiences syncopal episodes that recur despite being on a full, adequate dose of beta blocker therapy, LCSD should be considered and implemented without hesitation. It is a crucial step that must be offered before jumping to the most invasive option.
Which sets the stage for our third major therapy, mexiletine. This one is specifically gene-targeted.
Mexiletine really marks the beginning of true gene-specific therapy for LQTS. It was first proposed way back in 1995, immediately after LQT3 was linked to that SCN5A sodium channel gain-of-function.
And mexiletine is a sodium channel blocker.
Exactly. It directly counteracts that persistent inward sodium current. It is literally designed to correct the specific molecular defect that exists in LQT3.
So is it still reserved strictly for LQT3 patients?
Well, it is the mainstay for LQT3 to shorten the QTC, but its use is broadened significantly. Recent clinical data shows that in nearly 70% of patients with LQT2, mexiletine also shortens the QTC interval in a meaningful way.
That's fascinating. Why would a sodium channel blocker help in LQT2, which is a potassium channel problem?
It's a great question. It's likely because it interacts with the specific channel trafficking issues that are often seen in that genotype. It helps the faulty channels get to the cell surface more effectively, so it has become a valuable adjunctive therapy for LQT2 as well.
How does a clinician prove that mexiletine will actually work for a specific patient before committing them to long-term use?
They use what's called the acute oral drug test. The patient is given a single oral dose, typically 6 to 8 milligrams per kilogram, and their QTC is monitored very closely. To qualify for long-term therapy, the QTC has to shorten by more than 40 milliseconds within 2 hours of taking the drug.
And if it does, it's considered clinically significant.
Correct. And the patient is then placed on long-term mexiletine therapy.
Okay, so we've covered 3 highly effective tools: lifestyle and supplements, beta blockers, and then LCSD and mexiletine. Now we have to approach the final cornerstone, the implantable cardioverter defibrillator, or ICD, which you mentioned earlier, is highly controversial because of the extreme variation in how it's applied.
The variation in practice is genuinely shocking. We're talking about a major surgical implantation here. The source highlights that in some specialized centers in the United States, ICDs are implanted in nearly 50% of all their LQTS patients.
50%.
Now, compare that to 2 of the largest, most experienced specialty clinics in the world, the Mayo Clinic and the Istituto Oncologico Italiano. They report implanting ICDs in only about 5% of their LQTS population.
That is a staggering 10-fold difference. Why?
Okay.
What could possibly be driving a 50% implantation rate? Is it just a different interpretation of risk, fear of litigation, or maybe a failure to properly optimize those less invasive therapies first?
It's almost certainly a combination of all of those factors. Fear of litigation in U.S. medical practice often drives defensive medicine, An ICD is seen as the ultimate protection against a catastrophic death, regardless of the patient's actual risk profile after therapy.
And a lack of awareness about the other options.
I think so.
Yeah.
There's likely an over-reliance on those initial pre-therapy risk scores, and critically, a lack of awareness or training regarding the incredible efficacy of LCSD. If a physician doesn't fully appreciate that LCSD can eliminate 90% of shocks, they're going to default to the device.
So what is the consensus among the world-leading experts who wrote this review?
Their conclusion is firm. There is an excessive use of ICDs. The prevailing expert view is that most LQTS patients simply do not need and should not receive an ICD, especially when comprehensive optimization using beta blockers, LCSD, and mexiletine can achieve mortality rates approaching zero.
If an ICD is necessary, though, is there a preferred type?
Yes, an intravenous ICD is preferred over a subcutaneous device
Why is that?
because the intravenous placement allows for cardiac pacing, and pacing can become essential if increasing the beta blocker dose drops the patient's heart rate too low, or if the patient needs what's called overdrive pacing to interrupt an arrhythmic storm.
So let's clarify the precise scenarios where an ICD is truly justified, according to these experts. It sounds like it should be used as rescue therapy, not primary prevention for most people.
That is precisely the point. The source outlines 3 specific justifications. First, for any patient who survives a documented cardiac arrest while they were adhering to adequate drug therapy.
That makes sense.
Second, for patients who have syncope despite being on full-dose beta blockers, but only if therapeutic optimization, meaning LCSD and mexiletine, is unavailable to them. And third, for the true high-risk residual group, patients who still have syncope despite receiving a full dose of beta blockers and having already undergone LCSD. It truly is the last line of defense.
We also saw that red flag raised specifically about LQT3 with asymptomatic patients receiving devices.
Yes, that study was highly illustrative of potential overtreatment. It showed that 45% of LQT3 patients who received ICDs were asymptomatic. This suggests that the mere presence of that pathogenic SCN5A variant, which is easily identifiable on a genetic test, was deemed sufficient reason for implantation.
Bypassing the whole need for clinical risk stratification or seeing if other therapies work first.
Exactly.
This brings us back to the central theme of risk stratification. It's not a static picture at diagnosis.
No, LQTS is a dynamic disorder. It's a moving target. A patient's arrhythmic risk varies over time, and it changes with treatment. This necessitates continuous therapeutic optimization, often by adding mexiletine or considering LCSD as risk factors emerge or symptoms recur.
So patients need to be followed up closely. How frequently is that reassessment required?
The standard recommendation is follow-up visits at least once a year to ensure adherence, assess for any new symptoms, and allow for this kind of therapeutic optimization.
You mentioned that using those initial risk scores before starting therapy is a flawed approach. Can you explain again why applying the Schwartz score before treatment begins can lead to over-implantation?
This is a major point of contention in some clinical guidelines. Warnings have been issued against using risk scores at the initial visit before therapy begins. And the fundamental reason is that the initiation of beta blockers dramatically modifies the patient's propensity for arrhythmia.
So the risk score becomes obsolete once treatment starts.
Right. If you assess risk and implant an ICD based on pre-treatment scores, you are missing the crucial opportunity to reassess the patient after you've optimized their therapy. Data shows that among patients who were initially categorized as ICD candidates based on a score, only a small minority actually required the device once their drug therapy was intensified and optimized.
Let's quickly return to those genotype-negative patients, the ones who are clearly phenotypically LQTS. Are they managed any differently?
No. The data is clear on this. Genotype-negative, phenotype-positive patients should be treated identically to genotype-positive patients. Their clinical and arrhythmic risks are similar. Their diagnosis is clinical, not just genetic.
And finally, on the diagnosis front, the danger of misdiagnosis, particularly in athletes. You mentioned something called masquerading LQTS.
This is a vital point for sports cardiologists and pediatricians. Excessive intensive physical training, especially in teenagers, can induce a marked QTC prolongation that perfectly mimics congenital LQTS.
And you can imagine the psychological and life consequences of labeling a healthy teenager with a potentially fatal genetic disorder.
Immense! You might disqualify them from sports and cause incredible family anxiety, all for nothing.
So how do you differentiate this training-induced abnormality from the real thing?
The crucial differentiators are that these patients are typically completely asymptomatic, they are genotype negative, and they have no family history of LQTS. But the definitive clue is that this abnormality is entirely reversible.
Reversible?
Yes, the QTC returns completely to normal within 3 to 4 months of detraining. Recognizing this phenomenon prevents unnecessary long-term medication and life restrictions.
Let's expand our scope now to acquired LQTS, which is a common clinical problem, before we look at the future of treatment.
Acquired LQTS occurs when external factors are the cause of the QT interval prolongation. This can include conditions like hypokalemia, profound bradycardia, or heart block. But most commonly, it is caused by drugs that block the IKR current.
The same current that's mutated in congenital LQT2.
The very same one.
Many common medications, things like antibiotics or psychiatric drugs, can block IKR. What determines a person's risk when they take one of these drugs?
The risk really depends on two variables. First, the drug's intrinsic blocking strength, and second, the individual's inherent repolarization reserve.
Repolarization reserve. Can you explain that concept a little more clearly for us?
Of course. Think of the heart's electrical stability as a battery level. If you have a low repolarization reserve, let's say you have several common genetic variants that each mildly reduce the function of various ion channels, your battery is already starting at half empty.
Okay.
An IKR blocking drug is like a severe electrical drain on that battery. A person with a full reserve, a full battery, might handle that drain just fine. But the person with the genetically low reserve will suddenly cross the threshold of stability, and that results in acquired LQTS and Torsades de Pointes.
So acquired LQTS can sometimes unmask a latent congenital disorder that was just hiding under the surface.
Yes, that is often the case. The drug stress pushes a latent congenital LQTS, usually one with a very low penetrance or a mild phenotype, into symptomatic, life-threatening territory.
So how does a clinician decide whether to offer genetic testing to a patient who had one of these acquired LQTS events?
The source suggests offering genetic testing for the definitive disease-associated genes if the patient meets 3 criteria. They are under 40 years of age, they have a baseline QTC greater than 440 milliseconds when they're not taking the offending drug, and they have had arrhythmic episodes. Meeting those criteria strongly suggests there's an underlying low-penetrance congenital component.
And what does the science say about the polygenic risk here? How much do those common variants contribute?
The data is compelling. A combination of 61 common genetic variants that all influence the QT interval can explain up to 30% of the variability in acquired LQTS risk. It's a powerful, real-world example of how the combination of your genetic background and external factors impairs that repolarization reserve.
The idea that genetics drives acquired risk naturally moves us to the frontier. Gene therapy. Is this a realistic future for LQTS patients, especially considering how effective current therapies already are?
Gene therapy is a major area of interest, but the clinical challenges for LQTS are significant. The bar is set extremely high because, as you say, current therapies are so successful.
What's the main hurdle in developing gene therapy for LQTS?
The main limitation is variant specificity. LQTS is caused by hundreds of different single nucleotide variants across those genes, and each one results in a unique channel defect. Most of the current approaches, like gene silencing or direct gene editing with CRISPR, are variant-specific.
So you'd need hundreds of different treatments.
Which is logistically and economically prohibitive for any kind of clinical scale-up.
Is there a strategy that attempts to overcome this massive specificity problem?
Yes. The most promising approach is something called suppression replacement therapy. This strategy successfully corrected the LQTS phenotype in LQT1 and LQT2 cellular and rabbit models, and it did so independent of the specific disease-causing variant.
How does that work?
It involves simultaneously suppressing the activity of the defective endogenous gene while also introducing a healthy replacement gene copy. This comprehensive approach is much more feasible for clinical application.
But safety has to remain the core issue, especially when you compare it to a non-invasive pill or a relatively safe nerve procedure like LCSD.
Precisely. Gene therapies carry significant safety concerns, including documented severe adverse events, some of them lethal in other trials. Since our established therapy already provides extremely low mortality, gene therapy is currently only justifiable for the most high-risk patients who fail current triple therapy.
And who are those patients?
This would include the very high-risk infants who have cardiac events in their first year of life, or individuals with severe resistant variants. For example, a variant called PR1623Q in SCN5A, who continue to have appropriate ICD shocks despite receiving full drug and surgical treatment. For the vast majority of patients, the safety profile of gene therapy is simply not yet competitive.
Outside of gene therapy, are there any new pharmacologic approaches currently in clinical evaluation?
Yes, several promising compounds are being investigated. We mentioned the combination therapy lumacaftor-ivacaftor, which is already approved for cystic fibrosis. It's now being evaluated for LQT2 patients with specific ion channel trafficking defects. Another avenue is the inhibition of a kinase called SGK1, which has shown promise in LQT2 and LQT3 models by helping to shorten repolarization.
And to wrap up the therapeutic discussion, what is the standardized threshold of success for any new drug trying to enter the market for LTTS?
The clinical bar is high, and it's standardized. A new pharmacologic therapy has to demonstrate a QTC change that is clinically meaningful, and that is specifically defined as shortening the QTC by more than 40 milliseconds. As we synthesize everything we've covered today, the narrative of LQTS is really one of incredible progress. It remains a potentially lethal, often invisible disorder, but the existence of these highly effective and safe therapies means that almost all patients, when they're properly managed in specialized centers, can lead a normal quality of life.
And the review repeatedly stresses that critical nature of specialized care and expertise. This isn't something for a general practitioner to manage alone.
No. Correct management requires specific expertise in genetic arrhythmias. The complexity of risk stratification, of therapeutic optimization, of knowing which beta blocker to use or when to choose LCSD over an ICD, that is not for a general cardiology practice. Physicians have to maintain that high index of suspicion and then refer patients to high-volume centers with experience in treating LQTS for a definitive diagnosis and that customized, optimized management.
This has been a fascinating look at the intersection of genetics and emergency cardiology. Before we close, I want to return to that finding about the 61 common genetic variants that explain up to 30% of the variability in acquired LQTS. If polygenic risk scores are already playing this powerful role in predicting the risk of taking a simple IKR-blocking drug, how much will understanding a person's complete polygenic risk profile, not just for LQTS, but for general channelopathies, change the way physicians prescribe common, otherwise safe medications in the next 5 to 10 years? It almost suggests a future where a genetic score is mandatory for every prescription.
Thank you for watching The Funnel Effect.